literacy research to Southern societies, several of the faculty members there told her that health literacy did not belong in medicine and that this would be better suited in an educational conference. So we have come a really long way from that. And so my goal today is to talk to you about social determinants of health and health literacy. Start off with just a little bit of background. Some of you may have seen some of these slides about health literacy, and those will be brief. But really what I thought I would address with this audience is how to use health literacy in research, how it impacts doing informed consents. And there, the last section I have added is what about health literacy and websites? Because everybody wants to put everything on the web nowadays. And the problem is that's all well and good, but for patients with limited literacy, the web and websites offer a very big struggle. Speaking of the devil, that was Terry. So, and so that was kind of what I thought I would go through. I meant what I go through with informed consent applies to if you're developing patient education materials. It's the same ideas, the same principles. And so, oops. Sure. Okay, so what do health research professionals and researchers need to know about health literacy? Many of y'all already know health literacy is the ability to access, to understand, and use health information services to make appropriate health decisions. And the more in the medical field that we become about self-empowerment, patients taking care of self-care, this becomes more and more critical. Health, the other thing I'm going to talk about too is health numeracy, because health numeracy is definitely related, has a very big impact in research. We often don't talk about it. You can look at the information that has been put out. COVID was with COVID, and you could see how people do not understand numbers, what researchers are saying, what has gone awry, what the way we present information to the public. So health numeracy is the ability to understand and apply health information presented as numbers, tables, graphs, probability, and statistics. And health literacy is affected by an individual's capacities and by providers and health system ability to provide accessible, understandable, and useful information and services. Nearly 9 out of 10 adults have difficulty understanding health information that is routinely available in healthcare facilities and in the media. We've long since said you can't blame the individual. It's the providers, it's the researchers, it's us that needs to change what we're presenting. If you've ever learned anything about literacy and adult learning, you know that is a long road to try and bring somebody's literacy level up. And so that's not the goal. What the goal is to make information, is to take the patient where they are, to take the participant where they are, and move them forward. So like I said, COVID-19 shone a light on health disparities. Health literacy explains a range of health disparities linked to COVID-19: age, race, ethnicity, limited education, low income, and rural residents. Inadequate health communication. We have definitely seen what the lack of health communication, what conspiracy theories on the internet have done, have caused many vulnerable populations to be more further marginalized. And in uncertain times, interpretation and trust of testing information, vaccine messages, and statistics is essential. I can tell you that when we're teaching the residents and fellows now, one of the unfortunate consequence of what has come out of COVID-19 is that they're getting more patients who not only doubt what they say about COVID-19, but they doubt what they say about other health information that they're giving, and they're getting a lot of pushback. and you see a much more pushback against science. And what does that mean? And the lack of understanding of the public about how research works. I mean, all you have to do is get on Twitter or get on any social media, and when a study shows something different, the public, for the most part, doesn't understand that's what research does. You take it and you're trying to prove something, and if it doesn't prove that, or if it proves something different later, then that's what you report. And we've done a really poor job of communicating that's how research works. Every vaccine that you've ever taken, has risk. That's not unusual. The thing that we always tell our patients is every procedure that we use and participants, every drug you're on has been done because of a clinical trial. And I think it's our lack of messaging that has led to, and our inability to describe to people and to say it in a way that they understand it, has led to a lot of the confusion. So health literacy and the social determinants of health have overlapping issues. Both of them contribute to disease burden and self-management. Cardiovascular disease is 50 to 75% higher among adults with low education and income. It's 28% higher for Black adults versus white adults. Diabetes is 2 times higher among Black adults versus whites. Obesity rates is 57% for Black females versus 40% for white. So you can see how they overlap. And what's shocking is the disparities related to social determinants of health and health literacy and health behavior in Louisiana. In 2019, we ranked 50th in health and poor health behavior, 49th in health system performance, 49th in poverty, literacy, low birth weight, and STDs, 47th percent in obesity and overweight, 64% of Louisiana, compared to 70% of Mississippi. We always go, thank God for Mississippi. They're usually a little bit worse than us, but 64% of adults in Louisiana are overweight. We're 46 in diabetes and heart disease. From a research standpoint, we are a wealth to study. There is not a lack of disease. There is not a lack of problems. But part of the issue becomes, what are we doing and what are we learning to help solve these? Health literacy practices can help address disparities in clinical trials. This is what we know about disparities in clinical trials. They exist in understanding access and participation in clinical trials in biorepositories among adults with low socioeconomic status, racial and ethnic minority groups, and for participants who live in rural areas. Less than 5% of cancer patients enrolled in a clinical trial are a minority. Less than 5%, excuse me, less than 5% of cancer patients are enrolled in a clinical trial. And of these, less than 10% are a minority. Less than 3% of NCI cancer control studies focus on rural areas. I currently have an NCI cancer control trial focused on colorectal cancer screening in rural areas. And one of the great advantages that we have where we live in the state of Louisiana is neither New Orleans nor us, nor have I necessarily seen it with Pennington either, have trouble recruiting minorities. The patient population that I have right now is 64% African American and Black. It's not a mistrust of participating in clinical trials based on focus groups we've done with rural areas. It's just nobody does it. Nobody reaches out. It's hard to do. Some of my clinical sites are 2 hours away from me. You have to start doing federally qualified health centers. You have to make adjustments. There are, I think with the push with telehealth, I think you're going to see a lot more ability to do clinical trials in rural areas and include patients in those areas. So what are the health literacy challenges? One of the problems is we often fail to grasp that whether it's participants or it's patients don't understand what we've given them, what we've discussed with them. And patients, I can tell you, participants with low literacy hold that very tight to the chest. That is something that they tend to be very ashamed about. They don't want you to know that. And oftentimes, even as researchers, we ask yes, no questions. So you're never going to figure out that the participant has any issues understanding what you're talking about, because they're always going to go, I don't have any questions, and I understood what you gave me. Patient portals and health websites are typically overly complex, technical, and difficult to use and understand. And most people with low income have cell phones, but not computers or reliable internet. So communication is the key. The single biggest problem within the communication is the illusion that it's taken place. We often think because we said it, we put it out there, that people understand it. And that's not necessarily true. Alan Alda, who, there are some older people in here who watched MASH, who would know who that was, now works at Stony Brook. And he said, communication takes place when we observe people closely and get signals that we are on the right track, that we have started at a place they are familiar with, and we track their ability to follow us. So when you're talking about literacy, literacy involves, it's not just reading. It's reading, it's writing, it's communicating. You know, I always think I fix this slide. The E always reps. It's communicating, it's math skills, it's problem solving, it's judgment, it's interpretation, and nowadays it's internet skills. And so when they did the National Assessment of Adult Literacy, this was done quite a few over 20 years ago. It's actually probably almost 30 years ago now. 14% of the participants they observed had below basic, which meant they could not circle a date on a doctor's appointment slip. This used to be a huge problem when we had the hospital, when it was a state-owned hospital, because they did not give out appointments when you came in. They mailed them to you. They failed, and then we had tons of no-shows. Well, there's lots of reasons why you would have no-shows from that. One, it may not be a time it's convenient for you. Two, they could have read the appointment slip. Putting an appointment on a calendar is an organizational skill, which a lot of patients with low literacy don't have. And so they might not have done that. And so you had a lot of issues then. 22% were in basic. And that was based on one of the questions was determining when it's okay to drink before medical tests based on short instructions. Only 12% of the population tested were proficient. 12%. That's nationally. It's not just in the South. Or, you know, one of the interesting things was they did some of these questions in France. The BBC decided to see, actually they did it in England, to do some of these with just the person on the street. And what they found was they had the same problems we did. They just sound smarter because they have a British accent. So below basic is circle a doctor's appointment. Basic, these are some examples of the tasks they were supposed to do. Give 2 reasons a person with no symptoms should get tested on a cancer from a clearly written pamphlet. Proficient means you could calculate an employee's share of health insurance costs using. So this is what the math looked like back in 1998. Not much of it has changed. We have no purple parishes at all, which means that less than 15% of the population have low health literacy skills. As you can tell, the delta has where it runs along the delta has a really high level of low literacy skills, and that's still true. We know that health literacy is linked to poor health outcomes. People with health literacy are limited to use or less likely to use preventive services, accurately understand and manage their chronic disease, adhere to treatment plans, interpret labels, ask questions. They're more likely to have poor physical and mental health, delayed diagnosis, and increased ER use. So we need to do a better job of communicating with clients or our patients or our participants. Less than 1 in 5 patients can recall what providers tell them. It's common for patients to say they understand, yet to be poorly informed about their diagnosis. 20 to 30% of patients don't fill their prescriptions. 50% don't take their medicines as prescribed. That's especially true of the elderly. One of the studies found that if you take 3 or more medications, your probability of confusing your medication goes up. That's even more true now if you think about Medicare promotes getting your prescriptions mailed to you. So whether it's like Express Script or whatever, the problem becomes when your doctor changes your medication and you have your leftover medication in your cabinet and you haven't thrown it out. And we have lots of patients who take multiple drugs for the same thing or keep taking something that their doctor took them off of because it's still there. You know, they still have it, they didn't throw out, and they didn't understand it. Clinic visits and hospitalizations are shorter when we communicate better. And patients often need help and support in remembering to take their medicine. So the other challenge is with patients who speak a language other than English. This has been problematic. 18% in the US speak a language other than English at home. 54 million Latinos in the US, more than a third don't speak English. Health literacy among this group with limited English is also an issue. I know there are very few signs even now in Ochsner that are in Spanish or at our institution. This has been Hispanic patients more often like to want to include a family member when we did focus group with Hispanic patients. But one of the problems is providers or researchers tended to use the family member to be the interpreter. Well, medical terms and research terms are a lot different in Spanish. And their family members may not be familiar with these terms. And so it doesn't always, a lot of patients aren't comfortable with their family member being the medical interpreter. So health numeracy, we already talked about the definition. Health numeracy is a hidden problem of understanding numbers used in healthcare. This was a study that was done. You drink a whole bottle of soda, how many grams of total carbohydrates does it contain? And it's 67.5. And the way that you find that is that most people would multiply the number of servings by the number of carbohydrates. Well, they did it with 200 primary care patients. 73% had private insurance, 67% had at least some college, 78% read on greater than a 9th grade level, and 37% were on a math greater than 9th grade level. Only 32% were able to answer this correctly. I was a math major before I became a sociologist in college, and I tell people that I think math is like a foreign language. For people who don't do well in math in school, they avoid it like the plague. You know, I took 2 semesters of Spanish in college. Hola, ¿cómo está? I could probably say what other thing in Spanish. I don't ever use it. And I've forgotten it. Well, the same is true of math skills. And oftentimes we have a lot more tools. People use their phones, they use different things. And so for them to try and interpret what things mean becomes very problematic. I mean, the fact that 78% of these patients read on greater than a 9th grade level, but only 37% had a math level, tells you there is a huge discrepancy with math skills. We know that health numeracy is linked to poor diabetes knowledge and control. If you think about it, 90% of patients struggle to understand food labels. That's difficult. It's in small print. We have lots of information on a food label that you're trying to decipher. 67% had poor estimation of portion sizes. 25% could not interpret their glucose meter. 40% could not calculate their carbohydrate intake, and 30% could not dose insulin correctly. One of the things that you should pick up on that is how many math skills are required in taking care of your diabetes, in managing your health. Approximately half of US adults are unable to calculate a tip. That was a picture that Terry had taken of what somebody had written. You know, we can't figure out the tip on there. Now they've tried to like help you with the tip. On anything you go, they calculate it for you. 1 in 5 college educated adults don't know what is a higher risk, 1%, 5%, or 10%, or understood that 0.01 is the same as 1 in 100. How many times as researchers do you use percentages? How many times in the news media do we see percentages thrown out there? And people assume that we understand what it means. Only 1 in 21 OBs accurately estimated the probability that a child has Downs after a positive test. That tells you where we're at with numeracy. I always tell people when they want to say, how can I tell that somebody has limited literacy? And one of the things is you can't tell by looking. There are definitely red flags. I mean, you know, you can, when we do a literacy test, a lot of times patients that don't want to, even though we don't call it a literacy test, don't want to do it, they'll go, I forgot my glasses. You know, the printout is in really large print. But, you know, I mean, they'll say things like they can't complete their intake forms. They have frequently missed appointments. They can't give a coherent sequential history. They're maybe not taking their medications correctly. A red flag often is they don't ask questions. You know, I mean, when I don't understand something, I'm not embarrassed to ask a question. I'll just tell you I don't know it, you know, but they are afraid that that somehow makes them look unintelligent. And so they're not going to ask it. We know that key ways to improve health communication is to slow down and to focus on the need to know and do. Avoid medical jargon, use plain language, use pictures and teaching tools. I'll go over a few of these in informed consent. Limit advice to 1 to 3 concepts. Write brief take-home information. I would tell you, if you're ever writing something in a research study or when you're seeing participants, make sure you print it. Don't print in all caps. A lot of people can't read cursive anymore. Some people's cursive is really bad and it's hard to read. Teachback is really old school, but it is still one of the gold standards to getting to understand whether somebody understood what you gave them. Pictures may be worth 1,000 words, but which 1,000 are they worth? Do they serve the purpose? That's what you always need when you want to include images. Do they serve the purpose and can you tell what you mean? One of the interesting things was this was from childhood vaccinations that Terry and I did a study on. And one of the photos and one of the images was the stork. And we were doing it with young mothers. And she said, why is that bird on the front of this book? You know, that was an old concept. The stork was associated with babies. You know, but they didn't get it. So they're not going to pick it up. They're not going to look at it. You know, so your images are really important. We always tell people, like if you're doing colorectal cancer and you want to show a picture of the colon, show it in the body. Most people don't know where their colon is. They don't know what the squiggly thing you have on the page is that represents their colon. But when you put it in the context of inside the body and they can see an image of the body, they go, oh, okay, I get that. I know where that's at. Pictures help tell the story, locate them next to relevant text, place captions underneath them, use color if possible. This was from ACP guide we did that didn't use any measurements. We just did pictures. So patients could understand it. They didn't have to do math. Wasn't a cup, wasn't half a cup, wasn't 2 ounces. User-friendly, the important thing to remember is user-friendly is not dumbed down. Nothing irritates Terry and I more than for somebody to say, I'm going to dumb it down. All of us like simplified information. You know, have you ever got an email that goes on and you just want to go get to the point? We're all busy. We all like brief information. We all like things that we can quickly pick up. What's the point and what you want me to do? To evaluate materials, is it title client centered? Is the layout user-friendly? Do the illustrations tell the story? Is the key message clear and easy to pick out? What's the behavioral objective? Is the information manageable and is it culturally appropriate? So I want to talk about this in context of informed consent, because we've definitely changed to making sure that the push is on making sure patients understand and participants understand what they're signing in informed consent. And it's gone from persuading to teaching. Probably everybody in this room has, if you've ever had a procedure, has signed an informed consent. They definitely are getting better. I'm the interim chair right now for the IRB in Shreveport. But before that, when I still serve as this purpose, I'm the health literacy reviewer. And I can tell you that consent forms have gotten better. People have begun to do some. So I'll give you a couple of tips when I'm looking at consent forms that always the flaws that I find in them. But Winston Churchill, so I want you to know that everything I have up here are from actual consent forms that we've had. And so he said, this paper by its very length defends itself against being read. And that's very true of this. Now, this would be unusual to find, I would say, nowadays. There is a bigger push to use bullets to simplify your information. I will tell you one of the major issues I have that people have is they make the mistake of, if I wrote it in my grant, I'm going to copy and paste it into the consent. That is always a fail, because participants don't understand the lingo used in grants. It's usually dense. You're usually trying to impress a reviewer. You're not trying to simplify. Although I will tell you, as a reviewer for NIH and HRSA and CDC, that I do appreciate people who use bullets and who simplify things that I don't have to dig for. And so the same is true of consent forms. I mean, the idea is, think about the consent, because you have to remember, consent is not a document, it's a process. It's always a process. And with participants with low literacy, it is a repetitive process. I would say even with participants with adequate literacy, it needs to be a constant reminding of when they come in for visits about what is going on and making sure they understand what they're supposed to be doing and knowing why they signed up for this and knowing that at any point they can step away. I mean, I think that's key in all research is that participants often, I mean, that tends to be buried in the text. This is voluntary. You don't have to do this. So there's a consent checklist, and I'll have these slides. So if anybody wants to go back over them, they can. Is it written in plain language? Do you use consistent terms throughout? Is it written in active and not passive voice? Active is very important. You're asking the patient to do something. You're asking the participant to do something. Is it formatted for reading? Is it too long? Is the information manageable? So one of the things I'll do is just really quickly give you some ideas. So these are concepts that our patients don't understand often. Adverse events, and they're often used in consent forms, is a bad reaction. Alternative procedure, other choices. You would think that, authorize is a really big concept, that I authorize you to do this. But a lot of our limited literacy patients with limited literacy don't understand what that means. It means to give your okay. Benefit, well, being in this study, help me. Clinical trial, usually that is a jargon term. Most patients and most participants don't call them clinical trials. They call them studies. They understand the concept research. Control group, you're not getting the treatment. Determine means to decide or find out, and disclosure means to give you information that you give to us. So I mean, you should recognize these terms. They are in consent forms all over the place. But I can assure you that participants often don't know what they mean and they just skim over them. Like when they don't know what something means, one, if the paragraph is too dense, if it's too long, they're not going to read it at all. That's an automatic, I'm not even going to try. And that's why we talk about shortening the length of paragraphs. These are some others: notify, obtain, participate, placebo, protocol. You know, we write these day in and day out. We're used to seeing these, but that's our jargon. Just like physicians have their jargon, this is researchers' jargon. And we're the ones who understand it. And a lot of our participants don't. So what does it mean to simplify and shorten a complex language? You've been selected as a possible participant in the study because you have a moderate to very high risk of pulmonary embolism, and it is not known if retrievable vena cava filters reduce mortality or reduce recurrence of non-fatal pulmonary embolism, or if complications of vena cava filters outweigh the benefits in such patients. This is a consent form I worked on. You're invited to be in this study because you had a pulmonary embolism. That's a clot that goes from your legs to your lungs. You know, what was the whole point of that paragraph? That's what we mean when we say to limit what you put on there. Why are you being asked to be in the study? I will tell you that when the common rule came out and we were supposed to put very simple explanation at the beginning, those by far are some of the worst paragraphs I get now. You know, and I look at that and I go, that defeats the whole purpose. You know, they will go, I call it getting into the weeds. They get into the weeds about your disease and what we think and everything. The patient wants to know, why did you pick me? Why are you asking me? You know, make it simple and short and something they can understand. There are thousands of resources if patients or participants want more. And it's helpful to have to know where they can find it. If you want more complicated information, there is no shortage of that. And if they want more, they will ask you for more. They will say that they want something else. But it's better to simplify it and be very direct. So to make this more to the point, the goal of the tissue bank or repository is to support the LSU-HSC Department of Surgery research in order to improve our understanding of these molecular factors that contribute to cancer and that may lead to prevention and may lead early detection and cure. The goal of this research is to learn what makes cells turn into cancer. That's why we're doing it. You know, Terry and I have always said, simplifying material is not complicated, but it's tedious. And I always tell people one of the secrets that I use when somebody sends information to me to try and help them simplify is I take a paragraph and I just bullet it. I just take their sentences and the first thing I do is bullet it, just so I can see, okay, what do you have? What is your main point? And what can I pull out of this? And that is a good first step in just figuring out how to simplify something. You use active, some tips are use active, not passive voice. You break it into manageable chunks. We call it lumping and clumping it. One idea per short paragraph. That's what most people are going to remember. Try to limit your paragraph to 3 to 4 lines. Aim for less than an 8th grade level. I think people get hung up on readabilities. And, you know, the readability is just the tip of the iceberg. A patient with limited literacy will not be able to take a simplified brochure or information and handle it themselves. You've always got to discuss it with them, and you've got to repetitively discuss it. They'll get more information than they would have in a complicated, but we don't ever give information to patients and hand it to them and go, take this home and read it. It's like we go over it. That's part of the health literacy protocol, is having somebody discuss it. It's what our CRAs do when they go through consent forms. You know, patients don't, even low literate patients don't want consent forms read to them. They want it discussed. So manageable chunks this is a research project. You're being asked to take part of it because you have COPD. There are not many ways to treat COPD, so new medicines are needed to improve it. This study will test a new medicine. You can put in parentheses what the medicine is to help you breathe easier. The FDA has said it's okay. They've approved it to use with patients, but they haven't said it's okay to use it for COPD. And it's being tested because it may help you breathe easier. That's on a 6th grade level. And this is the idea of, I'm not going to read the whole paragraph to you, but one idea per paragraph. There were lots of things in this paragraph. You're being asked to take part in this study because you have prostate cancer. Researchers at whatever it is hope to learn if a hormonal tablet is helpful with prostate cancer. The effect of prostate cancer will be measured by a blood test. Keep it very simple, keep it short. Clean layout. We always talk about white space. Patients with limited literacy need room to breathe, and they need white space. So that's why you use bullets. You use headers, use bullets and less text. That's the same document is on the right. That actually is that vena. Well, that's the pulmonary embolism. They actually used a photo in that one. But that was what we did with it after. And questions are a great way to put headers. That's the great way to introduce headers, is it helps people locate the information on it. That's just another example of what bulleting and putting headers looks like, how to improve instead of condensed. I always tell people when you're doing risk, bullet your risk. I can't stand to get a consent form that the risks are all in one paragraph. That's really confusing for the patients. They miss a lot when you put them in paragraphs. If you bullet them out, at least they have an idea of what they're looking at. Okay, that's the misuse of bullets. You can do bullets wrong, by the way. And that's too much, and that's putting numbers, and you've just complicated. Headers are much better so that patients can try and skim and find what they're looking for. Develop it from the content, from the patient's perspective. One of the things to remember is, especially when we're talking even about research, a lot of our patients are going on to cancer clinical trials, or they're going on to clinical trials because that may be their last hope. When people are scared, they often underestimate risk and they overestimate benefits. Bioethics experts estimate that as many as 70% of patients enrolling in research believe, even though we tell them that the research may not help them, they believe that will offer them a direct benefit, despite signing the consent form that says otherwise. And so George Bernard Shaw once said, the single biggest problem in communication is the illusion that it has occurred. So a team of researchers found, can patients understand research findings? Found that the risk of X cancer was 1 in 250 in 2000, and they predicted it would rise to 1 in 150 by 2015. Focus groups found people were confused because many people thought that the number of cases decreased because 150 is less than 250. So you see how people are pulling out numbers and how they get confused. And they also wanted the risk numbers explained. Is 250 a lot? Is it a little? So one of the ways is to provide both positive and negative frames. 6 out of 10 men who have surgery to treat prostate cancer will be impotent. That means 4 in 10 won't. Be careful how you explain it. I'll show you a slide that the CDC does about when you say average, you have a significant, average is open to interpretation. It's open to all of ours about what we think average risk is. Keep the denominators the constant, keep the time frames constant. So this is one of the things that CDC, this is an excellent website they have on if you want to go on this. It's one of the best ones I've seen about understanding numbers. And if you talk about, it was giving you an example of using terminology, qualitative descriptors. The majority of women, average risk, some women, somewhat increased. What does that mean? Well, a way to put it in, and I often tell people when they're doing risk in a consent form, is if you're going to use a descriptor, put the percent beside it. So you have at least a better understanding of both of them. A majority of women, 75 to 80%. Some women, 15 to 20%. So you can see how they did it. They also tried to do a pie graph, which one I would tell you the colors are terrible on that, and our patients would have trouble picking that up. So using pictographs and pie graphs are a good way. Pie charts, it says to limit it to 6 or fewer. I would say you probably need to limit, if you're going to use a pie graph as an illustration, to probably 4. Because you put too many in there, and then, but I always go, make sure the largest is going and count is going clockwise. It's pointed at 12 o'clock so that they know how to read it. And use short labels. Infographics, the point on this slide is the size. By using different sizes of people, they made it confusing for patients. Be consistent when you use infographics. So one of the things you have to ask is, what are people, we always say, which one do you see, the bunny or the duck? Because you can see they're both. You look at it long enough, you see both the bunny and you see the duck. And which one is the participant focused on? I will tell you, hands down, Teach Back is the most effective way. And the best advice I ever got was a clinical trials nurse who said the way she does Teach Back after she's done informed consent is, she goes, I do this all day. And sometimes I miss something when I'm going over this with the patient. So I'm going to get you to tell me back some things that we went over. And I want to make sure that I told you. And therefore, you're not embarrassing the patient. You're not embarrassing the participant. You're putting it on yourself as the one who may not have explained it. And so there's a quick checklist to go over. But one of the things that I do want to hit is websites. And but one of the things I will tell you about research material is this has gotten better. There are a lot of questionnaires. PROMIS is tested on patients with low literacy, but most original questionnaires were tested on college students. So a lot of our participants don't understand the questions you're asking. Yes, no questions are terrible. Unless you follow it with, if you want to ask them, do you know what breast cancer is? You need to follow it up with a question that says, now, can you tell me in your own words what it is? We've done that on several studies, and surprisingly, not really surprisingly, the majority of people will tell you, yes, they know what it is, but they can't explain it to you. Because they'll just say, yes, I know what it is. That's why you don't use yes, no questions without follow-ups. Don't use too many Likerts. Don't limit them to 5. It becomes overwhelming. So putting information on the internet. Users with limited literacy skills generally read more slowly, and they reread words or sections or elements on a website, like buttons or menus, in order to understand them. And depending on the length of it, they may skip words or sections. They may start reading in the middle of a paragraph. If you think about what a web page looks like when you log on to it, and how you have different sections, you know, it's not like a page when you read it and we know how the direction goes. You've got to be focused on making sure those sections are clear and they're understandable about where they're in, because you never know where a participant is going to pick up with, especially a limited one with limited literacy. A dense wall of words can trigger limited literacy to skip the content completely. So one of the things I was going to show you real quickly is they did a study on a gaze of the gaze of readers when they were looking at a page. And this is what the gaze of a reader who does not have limited literacy skills look like. This is what it looks like with somebody with limited literacy skills who is rereading every word. One of the things that you need to understand is that patients and participants and people with limited literacy are decoding words first. They have to decode the word, and then they have to try and figure out, put it in the context that it's meant. So it's a slower process than what you and I read. This is what happens when they're only reading text that looks like they're easy words to read. You have to think about what format you're tailoring it for. I am really old school. I want to pull up, I do not like iPads. I just have never adapted to them. I have a laptop and I have a desktop. Everything is so much easier, and I'm also getting old, and I get that. But everything is so much easier to use. But look at what the difference in that format it looks like if you put it on a desktop, if you put it on a tablet, and you put it on a mobile phone. And guess what most of our low-income patients have, and limited literacy participants? They have phones. My 25-year-old does not use an iPad, and he only uses his laptop if he has to. He does everything on his phone. I can't even get it to, I'm looking at it going like this. But, when we're developing materials, more than 90% of people own a mobile phone. And if you're going to put stuff out there, you need to think about what it looks like on the device that you're using. And also patients and participants tend to have some familiarity with a mobile phone. They can figure certain things out. Younger people especially have grown up with mobile phones, so that's an easier option. One of the things that you have to remember, though, is mobile users are constantly scrolling. And because they can't see everything at once, what happens is it takes more time, it diverts their attention, and it introduces them the problem of reorienting themselves on where that was on the page. And so with content, don't overwhelm with content, don't use long sentences. These are the same principles that we talked about with consent. This is paragraphs versus bullets, headers and fonts. It's the same idea as when users scan web pages, they often are only reading headers. I do that. I'm looking at the headers, seeing is that it's something interesting that I want to look at. Consider questions for headers. We already talked about that. One of the key things, and this is the website is from, all of these are on a website from health.gov. If y'all want to pull these up, because it's a really good thing about putting stuff on the web. They talk about putting stuff above the fold. And that means you want the most important information before you ever have to scroll down to be above the fold, because that's what they're going to see. And that's the one thing that you can truly understand they saw before they get lost trying to scroll up. The hidden problems with web-based health information websites are too hard to navigate. Our rural patients have these issues. Internet spotty. It's not that they don't have internet, it's that they can't keep it it comes in and out. So if you put a video on your website and they may not be able to see it. The other day I was watching a video and I was somewhere and it was on my phone and the internet was spotty, and it was the most infuriating thing because when it pauses, so it's halfway through the sentence and it pauses, by the time it got through, I couldn't figure out what they were saying because it had paused so many times. Well, that's one of the things that you need to think about when you're thinking about things that you put on the web. I mean, at NIH, all organizations think, the web's the answer to everything. And what I would tell you is the web offers a lot, but you need to think about the target population if you're developing it for your participants or you're developing it for researchers. It's a very different skill set. And you have to think about how much use they're going to get out of it and how they're going to even find it. I mean, one of the things you have to think about is when everybody always talks about all these websites they're developing, I think if it didn't come up in Google, how are you going to find it? And for a lot of patients with limited literacy, Google isn't their strength because you got to know the terminology to be able to Google something. So that's one of the things. Icons, remember this is the same idea as when you're doing written material. And so the communication takeaways today, I know I went just a little bit long. Sit down and focus with your participants. Think about what you're writing for in your protocols, whether you're doing a conformed consent, whether you're talking about material you're going to hand them, whether you're talking about an oral discussion. We often do have, when I'm training research assistants that I have to use at federally qualified health centers, we have them constantly, I go, first of all, take it home give it to your mother, your brother, give it to your neighbor, practice it, and then come back, and then we'll have them go over it. Because when you start training CRAs to do stuff with patients and to do informed consent and everything, it's always really helpful to have that experience and to have done it quite a few times, so that you're not startled when you start doing your interviews, when patients don't understand, and like I said, the one golden rule we always talk about is teach back really is the most effective way if you want to understand, if your participants understood what you went over with them. And I will stop there. Does anybody have any questions?
They work a lot of rural areas, the access is like, we share a lot of the broadband needs in the state.
Yeah.
Get these kinds of.
Yeah, no, you really do. I mean, one of the interesting things is I feel like I have something on my lip. Sorry, I keep going like this because the FQHC ambassador has a really sharp CEO, and she is dynamite. And they have a running joke that at her house, her phone doesn't work because her internet access doesn't work, and she lives about 10 minutes from the clinic. And that is the reality of internet access in rural areas. It's hit and miss as far as where, access to it. I mean, I will tell you, in the rural clinics, all of the rural clinics I work with use Facebook a lot. I mean, they advertise on Facebook. They put their information. That's where their patients go to find out information about them. So they clearly have access. It just depends on if you're talking about phones and you're talking about, that's where the majority, even in Shreveport, the majority of our patients that come to Ochsner all have phones. They don't have laptops at home. These are low income. They don't have desktops, but they know how to navigate on their phone. But the problem with navigating on your phone is a lot of times do you have limited data? Do you have limited minutes? Is it a government phone? Our patients a lot will have different their phone will get cut off. Like they'll have used all their minutes or for the month, it'll get cut off, and then you have to realize it's going to be turned back on when they get paid or whatever the next month, like when we're trying to follow up with participants, just because the phone doesn't work one time, but but like you said, John, I mean, when you put stuff, even people who are used to using their phones to do everything on, websites are hard to navigate on a phone. And it's hard to get information, to simplify information. And so I always say, one of the things they also recommend is doing PDFs so that people have the opportunity to print off something, putting a simplified PDF on there or something they could print off, like whether it's their provider who would do it for them. A lot of times I know with our research participants, if there is something we want them to, whether it's sign up for a ClinCard, our CRAs walk them through that. Like they get their phone, they help them do it themselves before they leave the office. I know a lot of our providers will do that. Like if there's something they particularly want them to see, to find or use on the internet, they'll take the patient's phone and pull it up for them. And that's a that's a literacy principle, is that you just can't assume that people are going to be able to know how to do it, know how to navigate it, be able to get to it again. But yeah, that was a long roundabout answer to your question, John. But yeah, they do. I mean, internet has not improved that. I know that there's a huge investment coming in Louisiana to improve internet access, which is definitely needed. I mean, we're in 2023 and we still, people still have issues. Yeah.
You talk a lot about reading levels in addition to all of these takeaways or thoughts. In the good old days, we counted syllables to
Yes.
determine grade level. Now I know that Microsoft Word will tell us, but what's the gold standard for you for determining reading level from like a grade level, 6th grade, 9th grade level? What are you using?
I use Flesch Kincaid on Word. I mean, it's the easiest one I do, but you're exactly right. I mean, there are lots of, and I have slides on, there are lots of different ways to do reading levels and things that are out there. The easiest one is to do it on Word. It's just to pull it up and it'll calculate it to, things that go into a reading level are how long the sentences are, how many syllables are in the words. If you have lots of words that have multiple syllables, your reading level is going to go up. And I always tell people, the reading level is not the end all. It really is the layout, how you use it, and what you do with it. And the reading level is just the beginning of, of how to do that. Yeah.
Relatively, the interpreter say.
Yes.
Spanish speaking person, but as a physician, I always prefer having an interpreter doing the translation so that there is no issue in terms of understanding. But there's another issue that I think needs attention is there is diversity in Spanish speaking population, whether they come from Mexico, Nicaragua, Argentina, or Spain. They're all speaking Spanish, but they use words that mean different things in different countries. And that can be a challenge sometimes in terms of trying to elicit symptoms, and trying to understand the patient complaint. So,
No, you're exactly right. And that's a great point, is that, we're just not lumping people into one category. And that's what patients tell us, is that when we did the focus group with Hispanic patients, what they said was they preferred an interpreter and not their family members. Because they didn't, and they said a lot of times their family members didn't know what they were talking about. And they didn't trust them to adequately tell them, or accurately tell them what their provider had told them. They have a really good clinic in Shreveport that is one of the free clinics, is the Martin Luther King Clinic. And they have a couple of nurses that speak fluent Spanish. And so it pulls a large portion of the Hispanic population in Shreveport, because they know that. There's some FQHCs in Louisiana that have really large Hispanic populations for that very reason. They have providers who are language concurrent, and they have nurses, and that makes a huge difference on healthcare. But it's a shame that we only have such a select few. And I know that in Shreveport, interpreters are hard to get. We have, sometimes it's medical students who are fluent in Spanish that end up being the interpreter. I've heard that using the call line is pretty bad. When you call for an interpreter, there's a number you can dial and you get an exchange. I've heard those the providers don't like those. Anybody else? There is if anybody wants to stay for the workshop part, it's just to do a couple of examples. One of the reasons I offered the workshop part afterwards was if anybody had any particular questions. Y'all are welcome to stay, take a break. I'll hang around and see if anybody online wants to ask some things. But thank y'all for coming. I appreciate it. Thanks. I absolutely can.
Anyone else? I'll keep on you.
We'll step away for 5 minutes. I know there's some Everybody's got to stay in the workshop. It was just in case anybody was interested in going over the materials, but nobody. Thank you.